studying the duration of the APT, and we found out that actually it's quite a challenging decision, but it's not the only decision. And I think this session actually is perfectly complementary to the discussion that we had in the morning. So we have other strategies to deal with this delicate balance between reducing ischemic risk and increasing or reducing without increasing bleeding risk. So we're going to go through 3 different strategies to see how we can use them in clinical practice. So we have the first speaker, is Dr. Chema de la Torre, who will speak about monotherapy with potent P2Y12 inhibitors.
Hi, good afternoon. Thank you for all you that are resisting the dance program up to now. Chairman, I'm going to talk about new strategies as you presented, and this is monotherapy with potent P2Y12 inhibitors. We can see that there is a really change. We are really defining many other rules and laws we have in the treatment. For example, the APT duration. For many years was very classic, 1 month for bare metals, 12 months for drug-eluting, with the new drug-eluting stance, 6 versus 12. And now we have several options depending on the balance between ischemic and bleeding risks. Then things are very dynamic. And this is because the APT, we have a trade-off. We have really, the longer the APT, the more prevention of ischemic events, but the longer the APT, the more bleeding events we get. Then we have a trade-off that is difficult to deal with. Bleeding is not uncommon, and as I said before in another comment, many times the cardiologists underestimate bleeding because we believe that it's a secondary event that's not so severe as an MI or as a vascularization. But it's not an uncommon event, and it's becoming more common because we treat more and more complex patients with very old patients, renal disease, etc. And mortality after bleeding is important. It's even as important as after MI. And you see in this statistical analysis that BARC bleeding class 3 is as lethal as an MI. Then you have to keep this in mind. Why monotherapy? We presented, this is our journal, Interventional Spanish Journal of Interventional Cardiology. We started 1 year ago. And we contacted our colleagues, David Capodano, Rosana Merra, and Dominic Angiolillo, very well known in the field, to write this document, which is aspirin-free antithrombotic management following coronary stenting, myth or reality. And in their review, they just discussed the rationale for this approach and what were the evidences at the time of publication. And what is the rationale? The rationale is very clear. Aspirin increases the risk of bleeding, particularly at GI bleed level, gastrointestinal level. Aspirin is not a very good antiplatelet agent. It's weaker even than clopidogrel. Interplay between aspirin and potent antiplatelet therapies like anticoagulant is not synergistic, it's the opposite. The higher the dose of aspirin, the less is the benefit from anticoagulant. This was nicely shown in the plateau trial. And finally, withdrawing aspirin in patients with anticoagulation and clopidogrel is superior in safety and non-inferior in efficacy compared to triple therapy. We have been discussing this morning this, and there are several trials confirming this point. In the presence of a strong P2Y12 blockade, aspirin provides little. You see in this graphic the difference between the actions in the platelet level between prasugrel and prasugrel plus aspirin. There is no really a gain. There is no little additional benefit in antiplatelet therapy. This is a laboratory finding, but it reflects what could happen in the clinic. These are the trials discussed this morning in patients with atrial fibrillation and anticoagulation. In all of them, double therapy was compared to triple therapy. Sometimes with novel anticoagulation, triple therapies, and usually with vitamin K inhibitors. But the overall conclusion that we can get from all these trials is that double therapy decreases significantly and very largely the bleeding events after the procedures. And there is no detrimental effect on ischemic events. There is some stent thrombosis concern, but stent thrombosis figures are very low. it's very important to make a distinction between the confidence interval in the forest plot and what is the magnitude of the problem, because the magnitude of the problem in thrombosis may be 0.5 to 1%, and in the bleeding, the problem is 20% versus 5%. That's why I mean that the overall analysis of this trial suggests that for most of the patients, not all, absolutely not, but for most of the patients, double therapy after a triple therapy in the first maybe 4 or 5 days is the best choice. It's very clear in Augustus. In Augustus, a very good factorial design. We could really see that the aspirin is really adding no benefit in terms of efficacy, but is increasing significantly the bleeding when combined with anticoagulation and clopidogrel. What trials do we have with an early stop of aspirin post-PCI and keeping the patients only on P2Y12? The first trials are with only clopidogrel. The first is a smart choice. In this trial, after 3 months of DAPT, the patients were randomized to be on clopidogrel or aspirin plus clopidogrel, or DAPT versus P2Y12. This is not a pure clopidogrel trial because 23% of patients were on ticagrelor and prasugrel, but it's the first trial that's exploring the keeping the patients only in one single agent after 3 months. The results are here regarding the primary MACE endpoint is non-inferior, 2.9, 2.5, consistent across the subgroups of ACS stable and the different types of drugs, and decreased significantly the bleeding. The other trial is a STOP-DAP2 trial. In this case, a trial conducted with a single type of stent, science. Patients were randomized to 1 month DAPT versus 12 months DAPT. And in the experimental group, after the first month, the patients are on clopidogrel for 4 years, 5 years exactly, 49 months. And the other group is with DAPT for 12 months and then aspirin. The study is exploring then 1 year outcomes and 5 years, but they presented the results at 1 year, comparing the 12 versus 1 month DAPT. It's not a small trial, it's 3,000 patients, not very large, but it's not a small trial. Finally, the profile of the patients is not higher risk patients. To be honest, if you see the characteristics, there was some bias to inclusion of patients that were not at very high ischemic risk. Anyway, the primary endpoint, the net clinical benefit, combining ischemic thrombotic events and bleeding, it was in favor of 1 month DAPT, as you see in the slide. And it was split the ischemic endpoints and the bleeding, no difference in ischemic endpoints, but less bleeding with the 1 month DAPT. It's clear that these two trials are showing that a course of 1 to 3 months of DAPT followed by only clopidogrel could be an alternative in some patients, particularly in those that are not at high ischemic risk, but are at higher bleeding risk. But what about the topic of today, which is a monotherapy with potent P2Y12? We have 2 trials. The first is the Global Leaders. Global Leaders was really an ambitious trial because it's 16,000 patients, which is a very, very large trial in 130 centers worldwide, and was an important trial. They have a somehow complex design with many different alternatives because the experimental strategy was including patients treated with 1 month in DAPT, aspirin, ticagrelor, and then ticagrelor up to 2 years. And the reference strategy was different according to the presentation. In patients with acute coronary syndrome, the patients were on ticagrelor and aspirin for 1 year and then only on aspirin. And in the case of stable coronary artery disease, the DAPT was based on clopidogrel for 1 year and then aspirin. Then we have 3 different ways of treatment. This is 12 months. After 12 months, the primary endpoint is significantly positive for the experimental group. This you see on the right side that we have less all-cause mortality and less new Q-wave MI, a new Q-wave MI that was adjudicated. But the primary endpoint was not set at 1 year, was set at 2 years. Then at 2 years it's not significant. See, that is nearly significant. There is a strong trend, but the primary endpoint of all-cause death and new Q-wave MI is not. Interesting to see the adherence to the drug, 78% adherence at 2 years of ticagrelor, which is really lower, much lower compared to the adherence to aspirin. And the primary endpoint, as I showed to you in the last slide, was not met. You see the curves, but are very interesting because in the first year, it's true that all-cause death shows really an important trend to be lower in the experimental treatment group, but in the following year, there is no additional benefit gained by ticagrelor. With regards to the bleeding, in the first year, again, the experimental group is doing well because you have less bleeding, but in the second year, when you are comparing patients with ticagrelor versus aspirin, there is a catch-up, and the experimental group is having more bleeding, and finally, is really joining with the aspirin group. This is really important to see because I think it explains some of the limitations of the trial. I think that the trial was not significant for 4 reasons. The first is extending the study up to 24 months. Maybe with 1 year, the results would have been positive. Including stable CAD patients was a problem because no established benefit of ticagrelor in this population. In fact, there was a significant interaction for bleeding in the ACS group in favor of the experimental treatment. The primary endpoint was, in my opinion, overly ambitious. I understand this endpoint because all-cause mortality didn't need adjudication, and new Q-wave myocardial infarction was adjudicated, but if you add more endpoints that are not adjudicated, then you are going to be in certain trouble. But was a very, I don't know, the primary endpoint was maybe too much. And limited adherence of ticagrelor, this is a limitation, but it's inherent to the drug. You can improve the adherence to maybe 80 or 85%, but always it's going to be less than 90%. There was a sub-analysis of the trial in the 50% of the population with adjudication of events is the GLASI, but GLASI finally did not find any different. The results were consistent with global leaders, and they suggest that maybe, if you see the landmark analysis, the strategy of ticagrelor versus aspirin in the second year may decrease thrombosis, may decrease MI, and they now show a really meaningful increase in major bleeding, but this hypothesis generated. The multivessel disease group has been analyzed for global leaders in a paper published recently in JACC, and there was a positive interaction. It looks like that in the multivessel PCI patients, the strategy of ticagrelor for 2 years provides some benefit. As you see in the left side, the primary endpoint, with no detrimental or harmful effect with respect to bleeding. Then in the multivessel PCI, maybe a strategy like this could get more benefits. The second trial is Twilight. In the Twilight, the design is patients high-risk PCI, 7,000 patients, 3 months of DAPT, and then randomized at 3 months after non-eventful and an eventful period of 3 months, randomized to ticagrelor aspirin or ticagrelor placebo. And then we have the analysis of 15 months and 18 months for the trial. The inclusion required to meet one of these criteria in the box of the clinical and at least other one in the box of the geographic criteria to be considered a high-risk PCI. As I said before, over 7,000 patients randomized. And very quickly, the primary endpoint, bar bleeding 2, 3, or 5, significantly less, much significantly less common in the ticagrelor alone group, and ischemic events exactly the same figure at 1 year. The benefit was present in the acute coronary syndrome subgroup. They presented this group in the last AHA, and you see that the ticagrelor monotherapy provides less bleeding and equally protective against ischemic events also in ACS group. They were very aware of the limitations. The trial has also limitations, maybe not as evident or greater than in global, but in Twilight, there are also limitations that limit the applicability of this trial to the population we treat every day. Particularly, don't forget that these are patients that have an uneventful 3 months DAPT period. Then, at that moment, you can really choose for this strategy. The conclusions of the trial was that in high-risk PCI patients, we can consider the monotherapy of ticagrelor after 3 months of the APT with no events. And we can expect from that less bleeding compared to the APT and no increase of ischemic events. The thrombogenicity study, I'm going to take much time about this, 51 patients, no changes in thrombus area, and some differences in reactivity for some agents, more reactivity for aspirin, for the other agents similar, but no really differences. And then in what kind of patients we can really place this strategy? I think that you see this model, this graphic is from our institution. When we consider the bleeding risks and the ischemic risks, those patients with complex PCI in a stable of ACS and no really bleeding and high bleeding risk we can consider the 1-3 months APT followed by ticagrelor. But we are talking about ticagrelor a lot in these trials, even this morning in these presentations. But there is a recently presented trial, this is a RED5. In this trial, 4,000 patients have a comparison between the APT based on ticagrelor, the APT versus the APT with prasugrel. And the results were surprising because all of us, or I believe that most of the people was expecting just a neutral result, similar results. Or even better for ticagrelor for some people, but the results were really that prasugrel have better outcomes. Prasugrel treated patients have less events in 1 year follow-up, and bleeding was not significantly different. Then, with these results in mind, we have to think in the monotherapy with prasugrel could be an alternative, but this should be tested in warranty trials. The trial showed also that there was no different presentations, STEMI, non-STEMI, and stable angina. And there are trials going on, but the largest is with ticagrelor, the TICO trial, very similar to Twilight. But the trial with prasugrel is only 200 patients. It's just a pilot, a small trial. I don't think that prasugrel being a generic drug now is going to be the starting of any large trial, like the Twilight trial or the Global Leaders. But it could be really nice to see an independent or academic study addressing the use of monotherapy with prasugrel like was done with ticagrelor. In conclusion, we can say that antithrombotic treatment after PCA is becoming highly suitable to the variable patient's profile regarding the balance of ischemic bleeding risks. The APT duration is modulated. Now we have different alternatives. And in patients undergoing high-risk PCI, eligible for aspirin and ticagrelor, aspirin can be discontinued after an eventful period of 1 to 3 months and followed by monotherapy with ticagrelor for 12 months. Anyway, in the cases presented in the previous session, you presented the alternative for the Twilight and the Global Leaders, and very, very, very few people click the Twilight choice. I did it because I had the presentation afterwards. I had to be consistent, no? But I did it, but it was only 15% of the people. And it's because the same happened with the DAPT at the beginning of the trials, comparing 6 versus 12. Very few people was using 6 months APT. Double therapy in people with atrial fibrillation, very few people is using really double therapy. Most are using triple therapy for 1 month, 2 months. And this is the same, but even more recent because the trial was presented just in fall. But I support this strategy of really being able to really adjust the therapies to get the most benefit in thrombotic, but not creating problems to the patients with bleeding. Thank you.
Thank you, Dr. De La Torre, for the nice presentation. Are there any questions from the audience?
Yes, a nice overview. All studies so far go 1 to 2 years. It's nice to get rid of the aspirin because of the gastrointestinal problems and bleedings, but what after 2 years? Should we keep on sticking on ticagrelor, or do we just go back to aspirin after 2 years and accept the gastrointestinal bleeding again?
Totally true. The only hint we can get is from Pegasus trial, which is a trial in which patients that are in a chronic condition, they have an MI 1, 2, 3 years before. We also have TEMIS trial, which is working in the same direction. No? It's a strategy of taking patients that are chronic, they have an event maybe 1, 2, 3 years before, and put these patients in these drugs like ticagrelor. The problem is that in this situation is very clear a trade-off. The benefit you get in ischemic is the same harm you get in bleeding. And it's the typical example of the Pegasus trial in which really the net benefit was minimal. Then the ideal thing is to precise the therapy in the patients. What patients are really more prone to bleeding? What patients are more prone to thrombosis? And then to tailor the therapy. The problem is that always we are thinking in generalized strategies. What is the best for the patients with coronary disease? If you ask this to an oncologist, what is the best therapy for breast cancer? He will say, there is no best therapy for breast cancer. It depends on the patients. This is the same thing. I think there are patients that maybe in the future we will be able to identify that are better served with ticagrelor continuously because they have really an ischemic risk and the bleeding risk is very low. And there are patients that maybe can be on aspirin because they have identified by genes or whatever, resistant to bleeding, and they can be on aspirin, whatever. Then I think the only thing is to precise the therapy, to make precision. Scores, maybe, genetic profiling, epigenetic profiling, I don't know, but maybe it's that.
Thank you for the presentation. You conclude you can stop in some patients aspirin after 3 months, but why not stopping ticagrelor after 3 months? Because you have some evidence, some very beautiful studies showing after 3 months you can stop the ticagrelor and just continue with aspirin.
Yeah, exactly, it could be, but my talk was about monotherapy for potent P2Y12. This is what, if the talk would have been really aspirin alone, I could give some evidences in this regard. But in fact, these are patients with high-risk PCI. And I think that these patients, mostly ACS, in twilight, 2/3 of the patients were acute coronary syndrome. I think nobody's thinking of stopping the P2Y12 at 3 months and just keeping on aspirin, unless they are in a very high platelet risk. And in this case, you put patients on clopidogrel alone, not even in aspirin. But for the patients in twilight, it is the most, or even in global leaders, because in global leaders, half of the patients with acute coronary syndrome that you see a positive interaction. I think patients with this strategy is for patients with high risk of ischemic events. And in this circumstance, you have to keep the patients preferable in this strategy, not or DAPT or ticagrelor, but not in aspirin alone, at least for the first year. After the first year, in twilight, the patients are moving to aspirin. In global leaders, you have the second year included. And in the second year, the net benefit was lost. Then at least, that's what I say in the conclusion, is in the first year. Ticagrelor, the first year. After 3 months of the APT. Not aspirin, because it's a high-risk PCI patient. Acute coronary syndrome and high-risk PCI.
So just one remark to the studies that were done on clopidogrel. Both of those studies are done in Asia, and the second study also had very high rate of intravascular ultrasound, which we frequently do not do, so this might be some difference towards what we actually doing here.
70% IBUs, and the low risk of the patients. They're not these are not high-risk patients.
I have one question to the audience, like regarding low-risk patients. Who is actually shortening the depth therapy from 6 to 3 months? So it's only 3 out of all of here, but according to the guidelines, we probably underuse the shortening of the therapy.
So Chema, I mean, we have already trials with, you have shown the limitations. We have no strong evidence so far, and I couldn't agree more with you that it would be great to have a trial really proving what we would like to believe, that is that we can use that kind of strategy safely and effectively. What would be your design? Because you have emphasized a lot of the limitations of these trials, but if you have an ideal setting with the money and in another academic setting, what would be the trial that you would design to test this?
I would like to do, we had seen this morning in the presentations by Arisa, for example, about the scores in the elderly population. And we had seen in these trials that the elderly population is poorly presented. I would like to do a trial in people over 75 or even over 80 years old to see if really we get really benefits from these strategies. And maybe to try to look for the bleeding is mostly concentrating in this population, but the trials are not really focuses on this population. We need a very large involvement because to get a 5,000 patient trial in the elderly, you need a lot of centers and you need really a huge network. But it's the next step in the evidence to create evidences for the different subgroups. And I think the elderly subgroup really well deserves a proper investigation. And I will do a trial in ACS high-risk PCI, like Twilight, but only in people over 75 years old. That's it. And testing maybe 3 strategies from most aggressive or less aggressive to see what's going on in bleeding and ischemic. The problem is the flow is coming from the definitional endpoints. Depending on the point you establish, the trial results can be oriented to one or the other conclusion. That's very tricky. You know what I'm talking about. It's dependent.
Yeah. I mentioned that I don't like really academic studies in patients in clinical practice, but I do like it. I do like them in research. And I have an academic question. I think maybe it's actually nonsense, but it does make sense that if you reduce, let's say, the potency of antiplatelets, let's say you get one out of the two antiplatelets, you reduce bleeding, and you want to stay with the same level of efficacy. But I'm reminding the OASIS in which actually mortality reduction was nearly halved, and that was explained by the reduction in bleeding risk. So it was supposed that actually reducing bleeding risk would improve actually clinical efficacy. Why don't we see that?
Yeah, it's because of the numbers, I think, that, and the follow-up. Because you see the curves of survival after bleeding, they expand, they do huge changes in the survival in the years after. I mean, the patient bleeding has many times a harm that is evident not in the month or 2 months later, but in the following time. Because many patients, because they have the bleeding, you have a downgrade on the therapy, in the antithrombotic therapy, and these patients are more vulnerable to a migraine stroke. That's why in the survival curves after bleeding, there is like an increase, a steep increase in events 1, 2 years, even 3 years later, compared to those patients that have no bleeding, that are more, enter easily in a steady state, with a very small increase in events. Yeah. We need longer follow-up and much bigger sampling. That's why a big trial in elderly people will provide many insights. Yeah.
Okay. Thank you very much. I think we move on to the next presentation. Thank you. So Dániel Aradi is talking about de-escalation of P2Y12 inhibitors.
So thank you for the invitation and for the remote control of being able to deliver this very complex topic. And my role would be to discuss a potential role of de-escalation of P2Y12 inhibitors. So just to kick off, I would like to give 3 arguments why de-escalation may be rational in patients after PCI. And I will focus in my talk mostly in de-escalation to downgrade from potent P2Y12 inhibitors to a less potent strategy. So first, risk differences in ischemia and bleeding are different compared to early and late phases between potent and less potent P2Y12 inhibitors. In general, we can say that the highest risk of excess ischemia with the less potent agents come early, whereas the higher risk of bleeding occurs in the longer phase. The second argument is there are certain interpatient variability in the agents that we are using, and in the past 15 to 20 years we were focusing on less efficacy with clopidogrel and clinical influence of high platelet reactivity. However, you have to keep in mind that the excess of bleeding is maybe due to the excessive P2Y12 inhibition and the low platelet reactivity provided by prasugrel and ticagrelor. And finally, there are huge differences in patient characteristics between our patients that we don't respect with a one-dose-fits-all strategy from the guidelines. So to demonstrate this risk difference in ischemia and bleeding, we commonly refer to the Triton study when clopidogrel was compared to prasugrel. This is a very long story. I mean, it's like a 13 years old study, but it's easy to point out that most of the benefits with prasugrel came very early, generally in the first 2 weeks, where you don't see too large increase in bleeding. Whereas if you move and you reset the clock, you can observe there is still some benefit from the early phase until the 1-year follow-up in ischemic event. However, the magnitude of ischemia that you are reducing with prasugrel is in the same direction as the bleeding provoked. So the take-home message is not that we can stop prasugrel after 2 weeks. The main message is that after an initial period of large reduction in ischemia, the bleeding and the thrombosis are moving into the same magnitude. And there are some other colleagues saying that, okay, this is true for prasugrel, but it was not true for ticagrelor when the curves look like different. At least for bleeding, we see the similar curves which are diverging. So if you keep on treating patients with a more potent agent like ticagrelor, you will increase gradually the bleeding risk. However, the last years, the greatest motivation to keep ticagrelor was the mortality benefit, which was growing by time, and it was getting larger and larger until 1 year. But I have a question. Is it due to the special properties of ticagrelor, or is it due to the different patient subset of the Plato study? And we didn't have definite answers until we have studies directly comparing prasugrel and ticagrelor. The first study was the Prague 18 study, which was stopped for futility after 1,200 patients, and you see that there is no difference at all in mortality, and the curves look like the same. Reunión 5 study was also cited. It's a larger study and more recently published comparing prasugrel and ticagrelor. And although the study was designed as a superiority study for ticagrelor, at the end of the day, it ended up that prasugrel showed a lower risk of thrombotic events. And in the table, you see that even in mortality, there was not a hint of better mortality profile with ticagrelor. So overall, I don't think these two agents are so much different. They are providing stronger and more potent P2Y12 inhibition. As we can see in these graphs, compared to clopidogrel, both agents are more reliable. They are getting rid of high platelet reactivity that we usually refer to as non-responders, but they are provoking some parts of low platelet reactivity, which may explain the higher risk for bleeding. So what can we do to tackle bleeding? And this is two major ways of handling de-escalation. So this can be a clinically based de-escalation, which I would call unguided de-escalation. This unguided de-escalation was studied in the TOPIC study, which is a quite small study, 646 patients, who were after an ACS PCI, and after 1 month, they were simply switched back from a potent P2Y12 inhibitor to clopidogrel. What they found is that if you switch back from prasugrel or ticagrelor to clopidogrel at 1 month, you can reduce bleeding, which is not very much surprising, because with a lower potency of P2Y12 inhibition, you for sure can reduce bleeding. The question is there any downside, and do you have more thrombotic complications? And in the publication, they claim that there is no excess of any ischemic events. However, they do not cite any real thrombotic events, such as MI or stent thrombosis, and I don't believe this is really a real ACS high-risk population, because you see that the mortality is around 0.3 and 1%. In Hungary, at least, ACS PCI mortality at 1 year is around 10%. So I think this is really a low-risk population without a real power for detecting thrombotic outcomes. Other clinical potentials, as you have already heard, is not to downgrade from prasugrel or ticagrelor to clopidogrel, but to stop aspirin. But I don't want to go into more details, because you have heard in the previous talk. I would like to continue about another option, which is called guided de-escalation. So what is the basic principle of guiding the de-escalation? This is a meta-analysis of platelet function results in 20,000 patients from 17 studies, trying to find out what is the predictive value of platelet function testing in predicting bleeding and stent thrombosis. And as you see, compared to a reference, which I call optimal platelet reactivity, if you go to the left with low platelet reactivity, you will have an increased risk of bleeding with 2.6% absolute risk increase, which is important. If you go to the left side for more potent P2Y12 inhibition, you won't reduce stent thrombosis. On the other side, if you go to high platelet reactivity, you will have an increased risk of stent thrombosis, but you have a slight decrease in bleeding as well. So the basic principle of having platelet function testing as a guide to de-escalation is to go from this part with the potent P2Y12 inhibitors to somewhere this part, and don't let the clopidogrel patients develop high platelet reactivity, which may resume thrombotic complications. You may say that, okay, this is a very nice concept, but this has been completely proven that platelet function testing is dead. And there are 3 studies which were negative, randomized studies comparing platelet function guided treatments. However, I would like to draw your attention that these studies were not designed with the aim of de-escalation in acute coronary syndrome patients. These were low-risk stable angina patients with the aim of escalation treatment with the use of high-dose clopidogrel mostly. So it's clear and stated in the guidelines that you should not use platelet function testing in low-risk patients, in stable angina patients, to increase the potency of P2Y12 inhibitors. But now I'm not dealing with this topic. This is de-escalation in high-risk ACS population, which is a different story. And those who are knowing the platelet function studies may claim that, okay, we have another study in ACS patients where they try to de-escalate treatment with the help of platelet function testing, which is the Antarctic study from the group of Gilles Montelescu and Jean-Philippe Collet. However, in the design, there are 2 key things I'd like to draw your attention. First, this is not only de-escalation. They changed those patients who have very low platelet reactivity value from prasugrel to clopidogrel, but they also increase if they have high platelet reactivity from prasugrel 5 mg to 10 mg per day. So this is a mixture of de-escalation and escalation. So you don't really have one outcome, the impact of platelet function testing on bleeding or thrombosis. And this study was done not in an everyday patient population, but in an elderly patient population above 75 years. And the results were neutral, but they don't claim the de-escalation guided by platelet function testing is not useful, because this is a subset of 75-year or older, and this is something where not only de-escalation but escalation took place as well. So we come to a study which I think is relevant in the story. This is the Tropical ACS study, which was designed as a real de-escalation in a general population of acute coronary syndrome patients. And our aim in the design of this study was to have a control group of prasugrel, where we had 1 year of prasugrel treatment in patients. In the other group, we had an early phase treated with prasugrel to cover this vulnerable peri-procedural period, but then we switched back to clopidogrel and then tested these patients 14 days after the PCI or hospital discharge. And those who were, so say, good responders without high platelet reactivity, they continued clopidogrel, but those who had high platelet reactivity, they were switched back to prasugrel. And I would like to draw your attention how close we were to the ACS PCI event. So 7 days only on prasugrel after discharge. So from PCI, it was only around 10 days, very, very early de-escalation to clopidogrel. So 33 sites in Europe participated in this randomized study, and according to the primary endpoint, the group of guided de-escalation showed non-inferiority compared to uniform prasugrel treatment, 9% versus 7.3%. This was not a superior result by nominal statistical significance, but you see that the curves tended to be better in the guided de-escalation group in this composite outcome. If you separate thrombotic events and bleeding complications, the big question is, did we have to pay any ischemic risk by de-escalation to clopidogrel very early after PCI? And according to this part, there is no any hint of an increased risk of thrombosis, stroke, or cardiovascular death. And in any bleeding, you see the same signal, a tendency for a reduction in bleeding. What is clear and very important is that we had platelet function testing results not only in the guided group, but also in the control group. So we can have some insights about the utility of the platelet function testing device, how it can predict bleeding events, and is it reliable to keep patients on clopidogrel based on platelet function testing. So is it really an in vitro device, or can you believe what the platelet function testing tells you? So this is the platelet function data of this randomized study. So this is the usual clopidogrel response, 40% with high platelet reactivity. If you are using prasugrel, you will have more strong P2Y12 inhibition and a few patients only with HPR, but more patients with very potent P2Y12 inhibition. The first question is that, is it safe to keep patients on clopidogrel based on platelet function testing? And according to the results of the study, if clopidogrel is acting well, the results are completely the same as compared to prasugrel in this cohort of platelet function tested patients. The second question, is platelet function testing predictive regarding bleeding? So can you use it to predict bleeding and possibly to identify those high-risk patients who are exposed to bleeding? And according to the study, those who had low platelet reactivity, they had a significantly higher 74% relative risk increase in BARC 2 to 5 bleeding. In the different bleeding definitions, this not only constituted small insignificant bleeds, but very severe BARC 3 to 5 bleeding events. So the predictive value of platelet function testing on predicting who can safely use clopidogrel and who are potential targets for de-escalation because of the higher bleeding risk may be identified according to these results. In a multivariate analysis, low platelet reactivity was a significant predictor of bleeding events in addition to other characteristics such as age, female gender, low body weight, and non-STEMI presentation. So I think this is also a valuable tool in a risk prediction model what you are using in clinical practice to know who are those patients who are at high risk of bleeding and potentially candidates for de-escalation from potent P2Y12 inhibitors. So to conclude, I think I wouldn't recommend to use guided or unguided de-escalation in routine practice in your standard patients. I think the evidence is not strong enough to say that we are superior to the conventional uniform treatment pattern that are suggested by the guidelines, which are the potent P2Y12 inhibitors in ACS. However, I think platelet function testing has failed in the escalation field. It has some potential tool in the de-escalation strategies, because in the tropical ACS study we could prove that by using platelet function guided de-escalation, you can have at least non-inferior events compared to uniform prasugrel treatment, which is now considered the best strategy regarding efficacy after the ISA-REACT 5 study. So I think potential targets for patients to de-escalation are patients who are after a bleeding event, to know something about the potency of the P2Y12 inhibitor, and those patients who are at high risk of bleeding events, or although they are very difficult to be defined. Thank you very much for your kind attention.
Is there any question or comment from the audience? So I've always wondered about the results before they were released. If it happened to be positive, how would we incorporate it into clinical practice? Because I found that, I mean, one typical situation for thrombotic events, for bleeding, is switching. And it's also a source of confusion and so on. So I think this kind of very rational approach, which makes a lot of sense, I mean, probably would be able to be put in practice in highly academic centers, but in a widely spread hospitals routine practice, I have always been saying, well, God, if this happens to be positive, how are we going to implement this in real life? What is your view about that? This is more a general theoretical question.
I completely agree that I feel that a routine control measurement 2 weeks after discharge is extremely difficult in our routine practice to find a way to get the patients back and then have the test done, and the patient need to be asked to be switched back to clopidogrel and come back on 7 days clopidogrel. So this is something which is quite difficult to manage. But on the other hand, this is something which keeps the concept alive. So if you have any complication, not a routine patient-based strategy, but a complication, you can have some insights how to manage this patient. So let's say you don't want all the patients to come back to you at week 2, but you have a patient who has some hematomas, not big bleedings, but hematomas. And they ask, okay, doctor, I'm after 2 weeks of ACS-PCI, what can I do? And then if you don't have the tropical ACS results, you have no clues about potential value of platelet function testing and potential value of the results that you get on the platelet function testing method. With this, I can say that in these very selected patients, maybe I can consider, if it's possible, to do a testing and incorporate it in my clinical decision. I wouldn't say that platelet function testing on its own should guide our decision, but it can be integrated in a clinical decision where a patient with a bleeding, maybe it can be a nuisance or small bleeding, very short period after PCI, because it's relevant after 2 weeks, can be switched safely if the results are feasible.
Are there any further questions from the audience? So I think we are a little bit late in time. We can move to the last talk. Thank you, Dániel, for the excellent talk. So our last talk will be on dual therapy with rivaroxaban by Dr. Verhamme.
Thank you. And at the end of these 2 exciting days, I think it's really time to reflect on what is now the most effective antithrombotic strategy to protect your high-risk patients with chronic CAD or PAD. I think that's a quite easy question, and the answer is hopefully also clear after my presentation. I think the most effective antithrombotic strategy is low-dose aspirin and low-dose rivaroxaban. The more challenging questions are, well, how to identify patients at high risk for this combined therapy, and how to implement it in clinical practice, when to start, and how to select patients. But I must admit I'm a bit biased. I was part of the COMPASS study and a few other studies that looked at the low-dose Riva regimen. So my outline of my presentation, why combining anticoagulation and antiplatelet therapy? This is not the first time that this was attempted to. I will shortly overview COMPASS trial, and then I try to get some insights in how to select high-risk patients for this therapy. It's not the first time we combine oral anticoagulation and antiplatelet therapy. And if you look at historical studies, looking at warfarin for patients with CAD, looking at studies that combined warfarin with aspirin. If you look at these results, well, the conclusions are clear. In patients with established chronic disease, warfarin is more effective than aspirin. Anticoagulation is more effective than aspirin. And if you add aspirin to warfarin, well, you further increase the efficacy, but it comes at a price. And in general, and I think we are in agreement there, that the hustle and the bustle of managing warfarin in patients with CAD, well, the risks and the bleeding risk and the hustle and the bustle is no longer in favor to prescribing vitamin K antagonists for our patients. But anticoagulation beats aspirin, at least with vitamin K antagonists. If you look at patients with acute disease, and that's the Atlas II trial, if you add low-dose rivaroxaban, and the study was 2.5 milligrams BD or 5 milligrams BD, if you add that on top of dual antiplatelet therapy in patients with ACS, you reduce ischemic events. And you do not only reduce ischemic events, you also reduce mortality. There is a penalty to pay. There is some excess bleeding by going to triple therapy light in patients with acute coronary syndrome. And clearly, this low-dose Riva has not displaced clinical practice. It has not resulted in a shift in clinical treatment. But these are the data that are available. This fueled COMPASS. This was the basis for COMPASS. And COMPASS trial tried to answer some important questions. In patients with stable disease, chronic disease, CAD, PAD, and if we randomize these patients to standard of care low-dose aspirin, or rivaroxaban 5 milligrams twice daily, so a particular regimen without antiplatelet agents, or then the winner of Atlas II, the combination of low-dose aspirin and low-dose rivaroxaban. The results, you've seen these results. I think the trial provided important answers. And let's first look at the arm that we often forget, which is the Riva-only arm. The Riva-only arm that was statistically superior to low-dose aspirin when the trial was halted because of efficacy, but then during the further follow-up did not longer reach superiority. So that's not an approved regimen, but we do have important lessons here. If guidelines recommend anticoagulation only after 12 months of treatment in patients with the combined CAD and atrial fibrillation, that's mainly based on historical data with vitamin K antagonists. There are no data comparing or looking specifically at DOACs in the standard dose and the AFib dose in patients beyond 12 months when our patients suffer from AFib and CAD. So there is no data on DOACs as secondary prevention for CAD, PAD patients. This is some first answer, and you see that, well, there was no superiority of anticoagulation alone as compared to aspirin, but I think there was a clear trend. This is not the winner. The winner of COMPASS was the combined treatment of low-dose Riva and low-dose aspirin, reducing major cardiovascular events by 1/4, reducing by 25% myocardial infarction, stroke, and cardiovascular death. If you look at the components of the primary outcome, so you reduce MACE events by 1/4, you reduce cardiovascular death by 1/5, and not only cardiovascular death, also total mortality was reduced by 1/5. You halve ischemic stroke. You halve ischemic stroke in these patients. There was a non-significant reduction in myocardial infarction, so the cardiac outcome of this triple MACE endpoint was not significantly reduced, but there was a trend, and if you look at a more combined outcome, combining myocardial infarction with sudden coronary death and with cardiac arrest or sudden death, you do see that also coronary events are reduced when you provide these patients with the combination therapy. speaking in front of an audience of cardiologists, a critique that was often made to the COMPASS is, well, these patients who were randomized into COMPASS and who were randomized and had a history of myocardial infarction, they often had their myocardial infarction already a few years before inclusion. So what this sub-analysis shows is that the relative benefits of the combination therapy were preserved irrespective of when the patient had his myocardial infarction. Was it relatively recent, less than 2 years? The patients with a recent ACAs were not included in COMPASS, 2 to 5 years or more than 5 years, whether the patient had a history of coronary intervention or not. You see that the relative benefit, the relative risk reduction of that MACE outcome was preserved irrespective of when that patient had his myocardial infarction. Bleeding, if you intensify the antithrombotic strategy, there is a penalty to pay, and that is excess bleeding. If you look at major bleeding here in the study, there was a 70% increase of major bleeding. I think it's important to remind us that the definition of major bleeding here included all bleeds where patients were hospitalized. So if a patient had a nosebleed and presented at the emergency room, that was a major bleed. Second important observation is that the major bleeds mainly, or the excess of major bleeding was mainly in the first year. And major bleeding is front-loaded when you intensify the antithrombotic strategy. If you look at the further follow-up, which is highlighted here, you see that these curves go in parallel once you've reached 12 months. So major bleeding, excess bleeding is front-loaded. And what type of bleeding were more prevalent in patients on combination therapy? Well, it were not critical bleeds, were not fatal bleeds. There was no significant increase of critical bleeds or fatal bleeds, but there was a significant increase. And you will see here what's highlighted. It's mainly a significant increase of GI bleeds, gastrointestinal bleeds. There's no surprise if you combine aspirin and if you combine it with low-dose Riva. Both of these drugs have been associated with gastrointestinal bleeds, and we know that when patients have frail mucosal membranes and you treat them with a DOAC in addition to antiplatelet agents, that these patients will be more prone to suffer bleeds. So more gastrointestinal bleeds. There was also a second randomization within COMPASS, randomization to PPI or placebo. And it's important to highlight here that that second randomization did not show any beneficial impact of routinely adding a PPI for the prevention of GI events. And so even though 1/3 of these patients had some PPI at baseline, routinely adding a PPI to these patients was not beneficial. That's a second randomization and also a recent publication of the COMPASS group. GI bleeds, mucosal membranes that are frail, that are damaged, are more likely to bleed with a direct oral anticoagulant. And so it's also no surprise that if we looked at these patients who suffered GI bleeding, well, these patients were 20 times more likely to be diagnosed with GI cancer as compared to patients who did not suffer GI bleeding. And approximately 10% of patients who presented with the bleeding were subsequently identified to be patients with an underlying malignancy. So maybe not all of these bleeds are bad bleeds. So, well, we have a great strategy, reducing mortality by 20%, reducing cardiovascular outcomes by 25%. But how do we select patients? How do we select our high-risk patients? And if we looked at the trial, the relative risk reduction was pretty consistent throughout all subgroups of patients. So the patients who benefit most are these patients with the highest absolute risk. There's also, if you look at COMPASS trial, these 27,000 patients, well, they had events, but the event rate was not that particularly high. These patients were well treated. The majority of these patients received optimal secondary prevention strategies. How do you identify these highest risk patients where you would like to intensify antithrombotic strategy? Well, you try to identify these patients with the absolute, with the highest absolute risk. And which patients had the absolute highest, the highest absolute risk? But there were mainly polyvascular patients. So patients could be eligible for COMPASS when they had established CAD, but also with PAD. And patients that had both CAD and PAD were clearly patients with the highest absolute risk when only randomized to aspirin. It were also the patients with the highest absolute risk reduction of the combination therapy. Also patients with some features of heart failure. Let us remind that patients with established severe heart failure were not allowed in this study, and that the study looking at low-dose rivaroxaban in patients with heart failure, the COMMANDER-HF study, was a negative study. Patients with impaired renal function, patients with diabetes, patients with multiple risk factors, these were the patients with the highest absolute benefit. This is a regression tree analysis to identify such high-risk groups, and you will see on the right that these patients with polyvascular disease, CAD and PAD and or a history of stroke were clearly high-risk patients, patients with impaired renal function, an estimated GFR below 60, patients with some features of heart failure. These were the patients with the highest risk, patients with the highest absolute risk reduction of the combination therapy. Our patients, and these patients in COMPASS, were already receiving a lot of cardiovascular therapies. And so one of these important barriers to intensify antithrombotic treatments is, well, our patients are already taking a significant number of other therapies. The pill burden is already significant. And in this analysis, we looked at number of cardiovascular medications. And what we observed is that also here, the benefits, the relative risk reduction of the combination therapy was preserved also in these patients already taking a lot of drugs. And you will see that the absolute risk of an event increases in these patients who take more drugs. So patients already on a lot of cardiovascular drugs are patients at increased risk, and also these patients benefited most from the combination therapy. And on the right, you will see that the number of cardiovascular therapies was not associated with an increased risk of major bleeding. So pill burden should not dissuade us from intensifying antithrombotic therapy. It's actually these patients with a high pill burden that benefited most from intensifying antithrombotic therapy. We're not physicians to prescribe additional treatments. We actually are physicians who want to avoid prescribing pills to our patients. And how can we do that? We can do that by optimizing secondary prevention, by optimizing lifestyle. And so this analysis is of interest because here we looked at the baseline cardiovascular risk factors in these 27,000 patients. We looked whether they were well controlled at baseline or whether they had, despite our efforts, still risk factors that were not optimally controlled and in line with the most recent ESC guidelines. So we could identify patients that had a suboptimal blood pressure control, where lipids were not optimally controlled in line with guidelines. Obese patients, we identified patients with suboptimal physical activity below what is recommended by the guidelines, patients who are still smoking, patients with baseline diabetes. I also appreciate that in these patients with none of only one of these risk factors at baseline, the risks were low, the event risk were low, and also the benefit of intensifying antithrombotic therapy were preserved, but here with a limited absolute risk reduction. For these patients with a lot of baseline risk factors, despite efforts to try to control this, these were also patients at highest risk. So this may also help us to select these patients at the highest risk in whom we might consider intensifying antithrombotic strategy. So I think we have an additional strategy on top of others I think, a fantastic strategy that reduces cardiovascular events by 25%, mortality by 20%, and these are the highest risk patients: polyvascular patients, CAD, PAD patients, patients with additional risk factor, heart failure, chronic kidney disease, diabetes, patients with a lot of uncontrolled risk factors. There's a lot of discussion on, well, how does this COMPASS regimen, how does that relate to other strategies, antithrombotic strategies? Well, the COMPASS study was the first study in established patients to show that we reduce mortality, cardiovascular mortality, and total mortality. First study to prove that, since aspirin has also shown to do so. And if you put the COMPASS regimen into perspective with the other strategies that were discussed, aspirin, clopidogrel, combining aspirin with clopidogrel or ticagrelor, you will appreciate that, and maybe it's not really fair to do such a comparisons, but that's what we do in clinical practice. We do compare these strategies. You will see that the regimen combines favorably towards other regimens. So, Mr. Chairman, dear colleagues, if you reflect on what is currently the most optimal strategy, the most optimal antithrombotic strategy for high-risk patients, I guess the combination of low-dose aspirin and low-dose Riva is a good choice. It's not the only choice, but it is a good choice. The more challenging question is how to select and when to implement this strategy in the pattern of patients that are being transitioned from acute patients to chronic patients. Thank you for your attention.
Thank you for the clear but detailed presentation on the COMPASS data. So just picking up on your last remark, how do you actually do it, the transition from patients, let's say they have a PCI in ACS and you do the standard therapy for 12 months. So how are you controlling, or have you any impact on the therapy that is done in the outpatient setting?
I think that's the question. How do we select patients? In my daily practice, I work in a cardiovascular department, but I mainly see patients with vascular disease. And that makes it a little bit easier because there is no discussion on alternative antiplatelet agents in patients with vascular disease. And this is the first time you see a dramatic reduction in cardiovascular outcomes. You halve amputation rates with this regimen in patients with vascular disease. So one way of looking at patients that are definitely benefiting from this regimen are patients with vascular disease and CAD. And so if patients after 1 month are patients where you will not continue DAPT, but they have a history of claudication or they have carotid artery disease, well, these are the patients where you may want to discuss and say, well, you halve ischemic strokes, you halve amputation rates, if you switch to the COMPASS regimen. I think patients with multiple interventions, patients with multiple risk factors. But yeah, that is the challenging question. It is not that we've discussed a lot of individualization of treatment. There is definitely a room for this strategy, but it's not a clear algorithm where patients automatically are transitioned from that to the COMPASS regimen.
Are there any other questions from the audience? No? So thank you for your presentation. Thank you for the audience for the last being here to the last session. I'll hand over to the chairman.